more about atopic disorders, as well as discuss some of the medications that we would see in children who have atopic disorders. Right, so when you have a child who has moderate to severe eczema and even some forms of mild eczema, one of the biggest parts of their treatment is going to be topical corticosteroids. Okay, and the way that topical corticosteroids are prescribed, it's important to understand what the potency is of those corticosteroids, because traditionally what you're going to be doing as a provider when you prescribe these topical steroids to children is going to be starting low and going slow. So if the low potency steroids are not effective, then you can move on to the medium potency and, if necessary, for severe high potencies. I will tell you though that a child who's requiring high potency topical corticosteroids should be followed by a dermatologist or allergist, because they are more commonly prescribing these than the primary care provider. Here in the low potency and medium potency, these are where we would be most familiar in prescribing to patients with atopic dermatitis or a more chronic form of eczema. Hydrocortisone and Desanide are two very common medications that we use in children with mild to moderate eczema. Okay, one of the biggest things you want to talk about with parents is how they will apply this medication, and provide them really good education that they should have warm baths, short-lived, okay, so 5 to 10 minute warm water baths every single day. Eczema is a disease of a lack of hydration, okay? So warm baths are good to have. They need a daily bath, okay? So some literature that you'll read will say every other day, some will say every day, some will say, every third day. But if you think about logistically, children are missing hydration. So taking them away from water isn't necessarily something that's going to dry them out unless they are spending long periods of time in that water, which would then break down the skin. So 5 to 10 minute short baths. Once they get out of the bath, they want to lather themselves up with an emollient, okay? Leave them a little bit damp, leave them a little bit wet. Tell the caregivers not to dry them too heavily, okay? They can dry the hair, but let that water soak into their body, let it soak into their skin to increase the hydration. Cover them with an emollient in the areas that are not red. Okay, in the areas that are inflamed, you can cover that area with your low potency or medium potency topical corticosteroid. Okay, steroids actually work better when they are applied to wet or damp skin. So and then you want to make sure you tell parents, stay away from wool clothes and wool pajamas, because that material tends to pull off in shreds and it can make eczema worse. So stick more with the cotton materials, the materials that don't stick easily, and things that are going to keep the skin nice and cool, not too hot, especially at night when the children are sleeping. You can also recommend wet wraps, which is something that some dermatologists will do in severe cases. Actually put wet wraps of cloths around a child's arms, body, torso, legs, and then put them into long pajamas and let them sleep in that overnight. I will tell you though that compliance rates are not super high with that, because it tends to be a bit uncomfortable for children to sleep completely wet all night. It has been shown to increase moisture and health, and it is something you can recommend if you think your patient will comply, but it is difficult to adhere to with a pediatric patient. All right. Next, let's talk about antihistamines, okay? Antihistamines can be successful in treatment of atopic dermatitis, but as we move into talking a little bit about allergic rhinitis, that's also commonly used for children who have allergies in the upper respiratory system. Okay, so your first generation antihistamines are things like Benadryl, carbonoxamine. We don't use these bottom two as much as we use Benadryl, but I will say that we're not using Benadryl very often for allergies unless it is an urticaria or an allergic reaction, some kind of an acute response, simply because it is really sedating and causes heavy dizziness. Okay, instead, we have moved on to the newer generation antihistamines for long-term control of allergies in children, which is Claritin, Zyrtec, and Allegra. These are the generic names, the loratadine, cetirizine, and then phenylphexidine, or fexofenadine, sorry. I do see here that Some of these medications are not approved until they're older. That means FDA approved. However, I have certainly prescribed cetirizine to infants off label as young as 6 months old if they really need it, because there is literature to state and evidence to show that cetirizine is safe and effective as long as you are using it in an appropriate dose and managing these children closely. And one of the things I did discuss in your last module is the Harriet Lane handbook. If you will be working frequently with children, you definitely want to make sure that you're going to get a handbook that prescribes medications, not just FDA approved medications, but also off-label medications that are still appropriate for use in pediatric patients. Because the reality is that most medications are not approved for babies. Many medications are not approved for children, and also some medications are not approved for adolescents. Okay, so when I say approved, I mean FDA approved. However, you would still be able to practice using off-label medications as long as you are doing what any other prudent provider would see as fit for prescription and treatment plan for a child. All right. So, talking just a little bit more about these. Okay, antihistamines are fabulous when it comes to runny nose, okay, rhinorrhea, allergic conjunctivitis, swelling of the eyelids and eye areas, that edema that you see with the allergic conjunctivitis. They work wonderfully for those itching and runny type of symptoms. However, they're not super great at working with nasal congestion. So if you have a kid who comes in and they have been on antihistamines without a whole lot of success, and they are really a chronic diagnosis of allergic rhinitis, seasonal rhinitis, and the nasal congestion is just starting to affect their daily activities and it's really making them uncomfortable, then they should be managed with an inhaled corticosteroid by nose. Okay, nasal steroids are really the mainstay for treatment of severe allergic rhinitis when nasal congestion is a large component of that patient's symptomology. So if they have minor allergies and they're doing well on their Zyrtec or their Claritin and they're not having any problems, they seem to be managed with the antihistamine, you can leave their treatment as is. But if they need some relief and in the ability to breathe through their nose, then guys, give them a steroid. I know I talk over and over about being able to prescribe steroids, I think it's because I've just come in contact with so many people who are afraid to prescribe steroids because of there is certainly a long effect, negative effect list for steroids. But if they are used safely, then they are in fact safe, okay, to prescribe. As long as you're making sure that you're giving the appropriate dose, okay, same thing applies here with the nasal dose. Start low, go slow. If they only need one spray per nair once a day, then that's what you're going to give, okay? And making sure that they are using it correctly, because a lot of times medications are not effective, not because of the medication and the diagnosis they're prescribed, but because we are not doing our job to give the best education in how a child would receive these medications. Okay, so for an example, a child who's on an inhaled corticosteroid in the nose, you want to make sure you discuss with the caregivers, maybe doing a little bit of saline rinse and blowing the nose before giving that medication to get rid of the debris and to make sure that the nares and inside the nasal cavity are getting that medication adequately. All right, so I did have a list here of the types of inhaled corticosteroids for the nose that you would see, and also we would use these in asthma. These are really the ones that you would see for the nose. Most commonly prescribed is going to be their Flonase and Nasacort, certainly. And Nasacort is over the counter. So many parents do, and so is Flonase. So many parents have access to these quite easily. But it's your job to make sure that they have the appropriate education in how to use them, what is safe to use them, and then if they're not having symptoms, if they've come off that steroid, they can stop it. Okay, if they are a seasonal allergic kid in the spring, well then in the winter and the fall, they don't need to take it. If their allergies exist more in the fall, well then in the summer and the spring, they don't need to take it. Okay, making sure that you are educating that these are not lifetime medications necessarily every single day, they can be used PRN in seasons. All right, let's get rid of these tables here. Let's talk, hang on, a little bit, whoops, sorry, wrong one, about food allergies. Okay, food allergies are seen in children, okay, and incidence and prevalence does increase when they have other atopic things going on. An atopic triad is what we call kids who have lots of atopic things going on. It is common when you have a kid who is atopic in nature, okay, they're just an allergic kid, okay, for them to have asthma, eczema, and seasonal allergies or allergic rhinitis all going on at the same time. And right here in the middle would be what you would commonly see as food allergies. So a lot of those things kind of just all go hand in hand. If you see a kid who has eczema and also has runny nose, congestion, and yucky atopic allergic rhinitis, you're probably going to look back in their history and see they have a history of wheezing, diagnosed reactive airways, or viral wheezing every season in the January through March months. It is also common for kids who have these things going on to have food allergies. Okay, usually parents will recognize problems and rash or sensitivity, swelling around the mouth, urticaria. Okay, so that would be hives, and certain kinds of reactions in the skin and in the nose and the mouth when children eat these certain foods. Okay. And about 40 to 50% of children who have eczema actually also have concomitant food allergies, which will make their eczema worse, because what is atopic dermatitis or eczema? Okay, those go hand in hand. Really, eczema speaks to the more chronic nature of atopic dermatitis, but what is it? It's an allergic disease. Okay, so if the child has eczema and you know that he's allergic to something, you're not always going to find out what, but food in the infant is going to be one of the biggest things you'll think about. Okay, and that's simply because they will be drinking milk and they're exposed to new eating patterns as they get into that, 4 to 6 months of age. And as kids get older, and they start to eat things like peanuts and tree nuts and soy and legumes and fish and shellfish, etc., wheat, then you'll also see reactions with this if they have food allergies. And it's important to understand what some of the symptoms are that you can see in the different systems if the child has food allergies, okay? So food allergies can affect the respiratory system with asthma, croup, cough. It will affect the ears, okay? Chronic rhinitis. I see kids who have chronic fluid in their ears. If you have a kid that you can't figure out why they have so much fluid in their ears all the time, one of the first things should be coming to your mind is allergies. And give that kid some cetirizine or Zyrtec or loratadine or Claritin to see if it helps clear that fluid up, because allergies can cause unnecessary buildup in fluid behind the ears. Also, gastrointestinal system. They could have diarrhea. They could have the opposite of constipation, lots of gas, nausea, okay? Tingling and swelling around the lips, mouth, and throat. Those are all commonly seen in kids with allergies. Skin, that's probably the most common one we think of when we think of a child having a severe allergic attack. We think of pruritus, we think of atopic dermatitis or rashes, hives, and eczema. Okay, but the more serious ones are going to be the hypotension, cardiac arrhythmias, anaphylaxis, and pallor. That would be your circulatory system. And then with your central nervous system, you do sometimes see some drowsiness, fatigue, headaches, and even depression or irritability and excessive sweating. So remember that kids have various reactions to allergies type symptoms, and managing them can either be something you do in primary care, or outpatient with a specialist, or inpatient if it's an allergic emergency.